infective arthropathy of the shoulder joint. Yes, start.
Respected teachers, Govt sir, Sidevi madam, and my young bro sitting between the great teachers, Charvagan, seniors and dear friends. Can anyone identify these beautiful particles? Anyone? These are the uric acid crystals under polarized microscopy. Very, very beautiful, right? So the body will be making beautiful crystals inside the body, and that will get settled in some joints. And here I will be describing when the shoulder becomes a natural jewelry box. So different sorts of crystals will produce crystal arthropathy of the shoulder, the monosodium urate, the CPPD, the basic calcium phosphate crystals, and different crystals, but the same pain, the symptoms are same. Acute onset of pain, mainly during the night, pricking type of pain, which will hinder the sleep. And gout, the gout has got a history of more than 2,500-year-old. The oldest, one of the oldest disease recognized. Considered as a disease of the king or the rich man's disease due to the obesity prevalent at that time in rich persons. It's also known as the expensive wine and red meat crystal. Slide maripoyo. No, that is the part of gout. There's a historical plant. The name of the plant is that is naked man or naked female plant, because the flower will arise before the leaves comes. The type of lily which is known as autumn crocus. No. Now this the Colchicum autumn nail, from which in 1500 BC the first effective medicine for gout was produced, the colchicine. The gout, the shoulder says I am too good for gout, because the gout, only 0.8% of gout occurs in the shoulder joint. As any other joint affection, middle-aged, old adults, especially the males, are the disease is main in males in 40 to 60 years. Females only after menopause, because the estrogen is uric acid. Rare, but the classical punched out lesion can be there in chronic tophaceous gout of the shoulder. Another beautiful crystal, when you focus it on, this is a calcium pyrophosphate dihydrate crystal. This causes the pseudogout, right? The most common crystal arthropathy of the shoulder of the age of 60 years, peak incidence 60 to 80 years. It's rarely seen before the age of 50 years. Unlike gout, it most commonly involves the knee and the upper limb. This is a usual presentation, 60 or 70-year-old person with acute shoulder pain with swelling. And on X-ray, you may find the calcification of the cartilage. So there are 4 types of presentation. One is asymptomatic CPPD. You will find incidentally the cartilage calcification. And acute CPPD crystal arthritis, which is known as pseudogout, otherwise an acute periarthritis, some say as acute periarthritis. And osteoarthritis, in a person with osteoarthritis, you may find calcification in the X-ray. And the chronic CPPD inflammatory arthritis seen in the wrist and the MCP joint, which may mimic rheumatoid arthritis. The risk factors: age more than 60 years, previous history of trauma, which may produce secondary osteoarthritis, that may produce the CPPD crystals, and metabolic conditions like hypothyroidism, hyperparathyroidism, chronosis or hemochromatosis. Another beautiful crystal, this is the basic calcium phosphate crystal. And one among them, the hydroxyapatite deposition disease. Hydroxyapatite causes calcific tendinosis. That is the most common crystal arthritis of the shoulder joint. And there will be periarticular deposition of these crystals and the inflammatory process. And the shoulder is the most commonly affected. And age from young age to older age, 40 to 70 years, there will be calcific tendinitis, periarticular hydroxyapatite deposition. Acute calcific periarthritis can be there, very severe pain, acute pain. And hydroxyapatite induced arthritis. The hydroxyapatite enters the shoulder joint from the periarticular structure. That will produce a destructive arthritis, which is known as Milwaukee shoulder. Right? So you may find things like this, as George sir was showing, the calcific tendinosis and rarely the Milwaukee shoulder. And this study had examined the prevalence of calcific tendinitis in the general population. They have found that 2.7% of study participants had calcific deposits in the rotator cuff complex. Of them, only 34 to 45% were symptomatic. And this disease occurred most commonly between the age of 31 to 40 years, and occurrence of shoulder is 60%. And it can involve any of the tendons around the rotator cuff and even in triceps and the bursae. Next will be the infections of the shoulder. It is a third most commonly involved joint in septic arthritis, third only to knee 50%, hip 20%, and shoulder only 80%. Incidence is also less, 1 to 10 per 1 lakh person years. And even bacteria has got a gender bias. There is a male predominance. 50% have risk factors and the 50% bad luck. And again, the risk factors, the advanced age, the longer you live, the more bacteria you will meet. And the diabetes will seduce the bacteria into the joint. And IV drug users will deliver bacteria into the joint directly. And in rheumatoid arthritis, so bacteria will destroy inhabit in an already destroyed joint, and in immunocompromises. In all these groups, the mortality is also very, very high. And how bacteria will crash this joint, 70% hematogenous spread, direct inoculation seen in 20% due to trauma, surgery, and injections. We do a lot of surgeries into the shoulder joint, and contiguous spread from the adjacent things like skin on 10%. And injections, when you try to cure a disease, and that will become another infection. So in joint induction, there is something known as a third ray rule. So if you give a depot preparation of steroid into the shoulder or any joint, these crystals can induce inflammation in the first 2 days. So there can be an increase in pain in 20 to 30% in the first 48 hours. That is known as the steroid flare or the crystal flare. So if the person has pain started on the third day, that is a telltale symptom of septic arthritis. That is the third ray rule after a steroid injection. So the troublemakers are the pyogenic bacteria, the usual, rarely the tuberculosis will cause a dry type of arthritis, that is a Carizica, and fungus and viral, very, very, very rare. And who are the common villains? The staph 50 to 60%, strep 15 to 20%, and some gram-negative bacilli. The symptoms, the same as any other septic arthritis, shoulder pain, limited range of motion, joint effusion, erythema, warmth. There will be fever, increased acute phase reactance, and the increased WBC count. But there is a confusion. There is definitely a confusion, because in septic arthritis, fever is subtle in old and immunocompromised patients, and the studies have shown that only 1/3 will have fever. And in a crystal arthritis can also produce fever, chills, and rigor. And the third, the crystals may increase the acute phase reactance and the WBC count. So there is a confusion. the problem is caused by a gem or a germ, right? So how will we solve the confusion? And the most important thing to solve it fast, because in mortality in septic arthritis when untreated or treated late is as high as generally it is 5 to 15%, and in more than 75 years it is 25 to 50%, and almost 70% in persons more than 80 years. And the mortality is also very high in diabetic persons, rheumatoid and other immunocompromised patients. So what is the solution? That is, the solution is a arthrocentesis and the synovial fluid study, right? So the definite diagnosis from the synovial cell study can be done made in two conditions. That is, one is a crystal, second is septic. So in synovial fluid study, we will be doing 5 C's: the color, clarity, the cell count, crystals, and the culture. Naked eye appearance can give you 3 clues from color, clarity, and viscosity. The color usually, lightly straw colored. In non-inflammatory, that is a degenerative straw color, and inflammatory including crystals, deep straw or white. In infective, deep straw to purulent to white, green, or white cream, or even green. So this is a color on the left. It's a normal thing, lightly yellow in non-inflammatory like OA. Then inflammatory it will be deeply yellow. Then septic it is purulent. Next will be the clarity of the synovial fluid is inversely proportional to the number of cells. So there is more number of cells, like in septic or in inflammatory, it will be opaque. So these are opaque, the inflammatory including crystals are opaque, and the septic is also opaque. And viscosity, usually this will have a viscosity, egg white like viscosity or honey like viscosity. So in nearly all inflammatory and infectious joint disease, the viscosity will fall. This is a test for assessing the viscosity. The string sign, a drop of a synovial fluid will produce a string of 10 to 15 centimeter. You can also do it between your gloved fingertips. That will produce a string of 3 to 5 centimeters. So on the left, there will be this watery consistency, viscosity will be seen in infective or inflammatory, and this is normal, honey or egg white. So coming to the synopsis of the gross crystals, the color will be deep, the clarity will be opaque in sometimes, and viscosity will be low. Septic, definitely it will be white, the clarity will be opaque, and the viscosity will be low. So gross examination will be inconclusive to differentiate between crystal and infection. If you check for the sugar in the synovial fluid, the sugar will be less in infective and inflammatory joint disease. If you check for the protein, that will be high in both infective and inflammatory. So we'll go to the cells. What happens to the cells? In non-inflammatory, the cells will be between 200 to 2000. Inflammatory, 2000 to 50,000, and infective, it will be more than 50,000. But again, studies have shown that the highest, that means more than 50,000 count can be seen in gout or in other crystals, rheumatoid arthritis, and reactive arthritis. So we come across 3 types of cells in the synovial fluid: the neutrophils, the large mononuclear cells, and the eosinophils. And the normal in joint, the polymorphs will be less, right? So increased in septic and inflammatory. So more than 90% will be seen in septic arthritis. And the predictors of septic arthritis, one good study, they have found that 64% of septic arthritis patients have a normal serum RBC and 77% being febrile. And they have found that septic arthritis, the WC count in the synovial fluid will be more than 64,000. And the likelihood ratio of SA, so if the count is more than 1 lakh, the likelihood ratio is 28. If it is more than between 64,000 to 1 lakh, it will be less, just 2.8%. And when the WBC count, the polymorph count is more than 90%, the likelihood ratio will be 3.4. And if it is less than that, it will be 1/3, that is a 0.34. Coming to the crystals, this is a dictum. During an acute episode, it's rare to find crystals without neutrophils or neutrophils without crystal. That means in an acute crystal arthritis, there will be the the WBC will be engulfing, phagocytosing the crystal inside. So that is the telltale sign of a crystal arthropathy, right? So this is uric acid crystal inside the WBC. This is CPPD crystals inside the WBC. So because the crystals can be, you can see the crystals in the synovial fluid during an active or quiescent state. So crystals in synovial fluid does not exclude the concomitant infection because the crystals can be quiescent also. So gram stain and culture should be done. Coming to the organisms, so issues with gram stain is that the frequency, the number is less in the synovial fluid. The gram positive can become gram negative on antibiotic treatment, and the pathogenic organisms should be differentiated from contaminants. The most common contaminants are the throat contaminant from the doctor's mouth. So you should use a mask before aspirating. And culture, so the staff will give a good culture result, 90 to 100%, gonococcal 50%. If you prevent the mixing of lignocaine with the synovial fluid, that will spuriously make this culture negatives. So the lignocaine will kill the bacteria in the synovial fluid. If you are finding fungi and if there is a presence of hyphae in the synovial fluid, that is contamination. So the fungi cannot grow inside, form hyphae inside the joints. So presence of hyphae means a contamination. PCR is some promising and detecting pathogens in patients who have recently received antibiotics. That is the role of PCR. So management, if it's a crystal, you can inject steroids inside and prevent further attacks, like in gout with things like urate lowering therapy, preserve joint function. Septic arthritis, definitely there should be a aggressive course of antibiotics, and it should also preserve the joint function. And key takeaways: crystal clear diagnosis saves your shoulder, and sometimes a life. A shoulder, the responsibility of thorough history, clinical examination, apt investigation. When in doubt, aspirate it out. And good diagnosis is the joint responsibility of the clinician, pathologist, and microbiologist. And in acute crystal arthropathy, the synovial fluid you'll find synovial fluid with germs inside, the crystal inside the WBC. In septic, the WBC will be in lax with more than 90% of the PMNs. And the disclaimer, no actual shoulders were harmed deliberately during the making of the presentation, and thank you very much for the patient listening.
Thank you, Dr. Roy, for your excellent presentation. Now all the presenters can come to the stage and there will be a discussion.
Dr. Roy is known among medical fraternity, not among PMR, but among all medical fraternity in Kerala and also in India. So, a veteran speaker. And that is evident here through his slides also, colorful and catchy slides. And he is the person who makes everything informative and interesting through slides. And he is my colleague and he's new. Thank you.
So, these topics were all very erudite and informational. So, if there are any questions from the audience, the questions can come first before we conclude.
I have seen few crystals because mostly the incidental finding in crystal tendinopathy, calcific tendinitis. I have never seen a gouty crystal arthritis or an arthritis due to CPPD or BCP. ആരെങ്കിലും കണ്ടിട്ടുണ്ടോ എനിക്കറിയില്ല. It's a rare topic ആണ് എനിക്ക് തന്നത്. So, but the thing is that you should differentiate it from septic arthritis, because this septic arthritis will endanger the person's life. That is the main thing. You should differentiate the crystal from from the septic arthritis. That is the main aim of my presentation. So, is there any role for biological? I don't know. Sir. Is there? Sir, ഏതിലാണ് sir? Anaconda can be used. Okay, sir. In which crucial artery, sir? Okay, sir.
To Ramurthy, sir. Sir, you mentioned that the use of that RANGL inhibitors are not advisable for a Charcot's arthropathy.
No, it's recommend guidelines. I do not know why. They say no need, don't waste money.
Okay, but definitely the RANGLs can improve the quality of bones. Like RANGL inhibitors.
I have never used in the past 5 years, based on the recommendation, never used.
Okay.
You see good result. Okay. So when they give recommendation, they have done so much of work, isn't it?
And we usually advise crow boots, the Charcot restrained orthotic walker for these people. Of course, in the acute phase, we definitely use the TCC, but after that, we switch on to crow boots.
We make it, particularly when it affects the ankle joint, we also give crow. Charcot restrained orthotic walker.
And what is the dosage of vitamin D3 used for these people? Vitamin D3. You mentioned that vitamin D3 is extensively using in Charcots. What is the usual dosage you advise?
Sorry, I didn't cut your question.
Dosage of vitamin D3.
Vitamin D3,
Yeah.
okay. This brand we available in Tamil Nadu, cell call, that gives 1000 milligram of calcium and 500 international units of vitamin D, easily available. Two at a time.
2 at a time. And you are not using the loading dosage of vitamin D3.
We have not done. I strictly go with the recommendation and it works.
Thank you.
So if there are no more questions,
So, am I supposed to ask?
yes, sir.
Yes. So, my question is to Dr. Ramurthy. What is the role of patellar tendon bearing orthosis in acute Charcot's joint? Weight relieving caliper.
Make sure patient uses the patellar tendon bearing orthosis. When they go home, they may remove it, sir. That's the problem. It will work provided if he wears all the 24 hours time. Even offloading footwear, when they leave it outside, it's a waste. Okay, that's why he immobilized in total contact cause. So our question is correct. Theoretically, it works, but the moment the patient removes the orthosis, he will start weight bearing. That will damage the joints, fractures, the rocker bottom deformity.
So a question to you, sir. What's your experience with Charcot's shoulder?
I might have missed.
Charcot's shoulder.
I have not come across. I might have missed.
We've seen even in patients with cervical spine injury, a few cases of Charcot's shoulder. In syringomyelia.
Okay.
So actually, we thought we would be presenting shoulder as well with this.
Okay, I was an odd man out. I presented a totally different topic.
But it was a very interesting one, sir. So in advasive capsulitis, we have done a study, and we found that a lot of non-traumatic shoulder pain is significantly associated with metabolic syndrome, sir. And supraspinatus tendinitis are very much associated with hyperuricemia. So these were findings we got in the department.
There are some rare causes for usually mistaken for adhesive capsulitis. Example, Pangos tumor sometimes present as stiff shoulder, and similarly secondaries. CA stomach, that is some sign is there. Usually that present as adhesive capsulitis like picture. So that should be differentiated. That is a rare cause also. So that is not the commonest one. So that should be considered if unresolved cases. Okay.
Sir, regarding hydrodilatation, should we stop or should we continue?
I have no personal experience with the hydrodilatation, but I have seen patients coming after hydrodilatation, and I don't find any difference in the outcome. So my personal opinion is against hydrodilatation, but there are people who are still using it. There are proponents of hydrodilatation. Maybe their experience is good. I have not tried it because I don't believe in it. I have tried manipulation under anesthesia on few occasions, but my results were, initial result was good, but after 2 days, again going back to the original situation. So I stopped that also.
Arune John was conducting it. He told that it is better.
Maybe their experience it may be working. Only thing is that after whatever may be the procedure, hydrodilatation or manipulation or whatever it is, the post-operative period should be very carefully treated. Usually what happens after dilatation or manipulation, you send the patient to a therapist. And what does he do? He vigorously mobilizes the shoulder once a day. For the next 23.5 hours, the patient is simply keeping it like this. So that negates all the positive outcome. That is the problem. If the patient is able to mobilize the shoulder very frequently after the procedure, maybe it is beneficial.
Sir, Ramamurthy sir, podiatric clinics are often there in majority of the hospitals in Tamil Nadu. Podiatric clinics. Here they are less. They are wide in Tamil Nadu.
There are many, and in our medical college, they have given standing instructions. All the surgical inpatients who have diabetic foot problems must be referred to podiatric clinic for assessment and offloading footwear. It's a big support to me. Private setup, I don't remember. Okay.
Question to Roy. Wonderful cinematic presentation. All the presentations were good. Question from the mind. Do you, in the real life clinical scenario, how often do you find and have you seen crystal in the synovium and also AFB in the synovium? In the entire life, I haven't seen. What about you?
I have seen one patient with AFB in the shoulder joint. One patient, the years back. Crystal I have not seen.
So with that, we will conclude the scientific session. Thank you, dear speakers, for the excellent topic presentations.
May I now request Dr. Abdul Ghafoor sir to kindly present a memento to Dr. Joe Joseph sir. I request Dr. Sridevi Madam to kindly present a memento to Dr. Ramamurthy sir. May I now request Dr. Charvagan sir to kindly present a memento to Dr. Roy sir. I now request Dr. Pradeep Kalatil to kindly present a memento as a token of our gratitude to chairs of the session